Fantastic. Our number is on its way up. So welcome everyone. We're going to get started. Let me just give a chance for everyone to get on. We're super excited to have everyone on this afternoon. So good afternoon and welcome to your Benco webinar, Gateway 2021, Crossing the Bridge into Dentistry. My name is Kay Huff and I will be your Benco host for tonight. Before we get started, I always have to go over the CEs to make sure that everyone clearly understands what we need. So number one is each person that wants CEs must have signed in their legal name. So whatever is on their license, that's how you need to sign in for the webinar, because that's how your certificates will come. Also important that each person that registered must sign on their own computer. In other words, you can't watch it with someone else. We need to know that you're actually signed in. Also, if you're watching with your telephone, it's really important that all we can see is your telephone number. So what we're going to need you to do is we're going to need you to email me your name, your telephone number, and the title of tonight's course to practicecoaching@benco.com. Again, that's practicecoaching@benco.com. Don't worry, I will go over it again at the end of the webinar to make sure that everyone has it correct. Also, at the end of the webinar, you will be receiving a survey. Please make sure that you fill the survey out. We want to know what you want to see in the future. What do you want more information on? We want to make sure as Benco, we're bringing you everything you need to run your practices successfully. Also, at the very bottom of the screen, you're going to see a Q&A. Please make sure you put all of your questions for the doctor in the Q&A, and we're going to stop at the end of the webinar and give about 15 minutes to go over all of those questions live. However, if we don't get to all the questions live, don't worry. What we're going to do is doctor's going to respond to all the questions, and everyone that came on this afternoon will receive a copy of all the Q&A. So with that being said, let's get started. I'm honored to introduce one of the most outstanding leaders in the dental field today. I am super honored tonight. We have one of the managing directors on, Rick Cohen. Hi, Rick.
Hi, Kay. Thank you so much. And thank you to all who are joining us tonight. We've got a great program and really very, very excited to introduce you to Dr. Janelle Animalici. And I'm going to read Dr. Animalici's bio real quick. I'm sure, well, here we go. Comprehensive care of the growing child is the cornerstone of work Dr. Animalici does as teaching faculty at Children's National Hospital, MedStar Georgetown Hospital, Georgetown Law, and as owner in her own private practice, clinician, Children's Choice, Pediatric Dentistry, and Orthodontics. She is a graduate of Duke University in Durham, North Carolina, and the University of North Carolina Schools of Dentistry and Public Health in Chapel Hill. She is also a graduate of St. Joseph's Regional Medical Center Pediatric Dental Residency Program in Paterson, New Jersey. Her national and international work has focused on children with craniofacial abnormalities, tethered tissues, and their link to poor oral health and health equity for children with special challenges. Dr. Animalici has prepared a program for all of us today. I happen to know you're going to love it, and I really look forward to what we can learn together with Dr. Animalici. So over to you, Doctor. Thank you.
Thank you. What if your child struggled to breathe during the night? What if your child stopped breathing during the night? What if your child stopped breathing 42 times during the night? Well, this was an issue with a kid named Nicholas, who is now 5. His parents were well-educated, attentive, first-timers, and for 2 years, they tried to figure out through multiple specialists while Nicholas struggled to breastfeed, always had a cold, cough, or congestion, no matter what time of year. Nostrils flared, bottom tier of the growth curve. What would you think as a parent, aunt, uncle, grandparents? until his parents was in a course that talks about proper growth and development for their child, and the light bulb went on. Action had to be taken. It seemed so simple, but a sleep study that his parents had been asking for 2 years was the cure. That sleep study did happen, and Nicholas had severe obstructive sleep apnea and went to surgery almost immediately, within a week. He's not in the 7th percentile anymore. He's in the 46th percentile for growth, no more snoring, no more summertime colds, a different child. Tonight, you will pick up the essential tools for effectively evaluating a child patient through the initial stages of growth and development. There are 4 tools that we will be covering over the next hour. Feed, speak, breathe, smile. Come along for the ride. On this webinar, I also want to interact. So feel free to put questions in the chat. I want to know what you're thinking, what questions you may have. And I know that we're monitoring what's going on, and we'll answer those at the end. But really, let's start. Why should we focus on the whole child? For growth and development, or anything. And for the purposes of this presentation, we're going to be looking at the head and neck, but it's connected to the body. So it's all a part of a system. 90% of the face is done growing by the age of 13 or 14. So if we're here to make changes, we have to do them early, methodically, and as a team. Let me take you back to embryology. Don't shudder. I didn't realize I needed to pay this much attention to it until we got to this stage in my 15th year of practice. And as I continued to learn more and more, I said, oh gosh, this is so absolutely important. I was taught growth and development at the University of North Carolina, Chapel Hill by the guru, Dr. Phil Prophet. You know him? Wonderful, wonderful, wonderful educational opportunity to learn and grow from the guru. And those things I taught and those things I learned about growth and development, I've taken and grown each year in practice. As teeth are developing, starting at about 4 to 6 weeks in utero, we have a system that's developing entirely around it. So because it's a system.
Excuse me, doctor. Let me just ask you a question really quickly.
Of course.
People tell me that some of the volume is gone. So this is what I think we might do, because I want people to hear your message loud and clear. What I think we may get you to do is either try to unplug the microphone and get a little closer, and let's see if that doesn't work. And then if that's still bad, I really want for your message to be clear, that we'll get you to call in and we'll do it that way. So let's try without the mic for a second. Go ahead and talk for me.
Is this any better?
Go ahead a little bit more.
Any better now?
That's better. Try speaking up louder like that. And then if it doesn't, if I get any more, I'll let you know and I'll get you to dial in. Okay.
I'll do it.
Thank you so much.
So as I was saying, there's an entire system developing around the mouth and the teeth. And we have to pay attention to each system as it's developing orally. So tonight, I don't have the whole time to highlight each phase of feed, speak, breathe, and smile through adolescence. I'm actually hoping Benco invites me back. But we'll look at each phase of what we have through about infant to toddlers, and then we'll take a step more into looking further beyond, keeping in mind that all of these things are happening honestly in tandem, in different phases, in different mechanisms in the body. Our goal, recognize, treat if we can, or refer. I clearly remember this in dental school with oral pathology, and it's the same in what we're doing and looking at this evening. Let's talk about feed. We're going to be discussing again infant and toddler feeding. And there are different types of swallowing disorders that happen. A swallowing disorder is really the difficulty or inability to transport the food or liquid from the mouth into the pharynx, then into the esophagus. And it can occur in different phases, an oral phase, a pharyngeal phase. We can look through all the phases and then determine what's happening. Is it oral? Is it pharyngeal? Is it esophageal? What are the signs and symptoms? And that's what we're going to talk about a bit as we're looking into feed as a whole. And it's the first piece of our puzzle. What do we know about feeding? One of the things from seeing so many kids is that feeding relationship is a very complex system. When we look at this diagram, we look from infant to toddler to our older children, and we see that starting from infancy on through toddler to teenagers to adulthood, things change dramatically. There's a significantly higher laryngeal position, thus a smaller space between the mandible and the hyoid, which provides anatomic protection of the airway, permanently heightened until the first 2 years of life. Then kind of turns into adulthood by the age of 4. Large tongue relative to the oral cavity as an infant. We don't really have the musculature or the motor control to manually move the tongue, the jaw, or the lips as an infant, but progress to that more as we move through toddlerhood to older adult or teenage years to our adulthood years. So this feeding system that we're looking at, as complex as it may be, we have to know what's happening during those times, because we have to know if it's normal or if it's abnormal during those times. Let's look at this oral motor development. Before birth, in the womb, sucking is already observed, swallowing is observed. At birth, and you can see this continuing to move through the trajectory. The mouth opens to suck, especially if hungry, to hungry cues. Then the gag response happens. The tongue moves in and out. Again, we move from 2 weeks to 9 months, and all of this is happening during that time. What else is happening during that time? Teeth may be coming in. Teeth are already developing, right? At 6 weeks in utero, but teeth may be coming in during this time. And so now we're experimenting as we're moving along and along with different types of food, different textures of food. At 2 to 9 months, the mouth can open for a spoon at an earlier age, but really ready for that complementary feeding between 4 to 6 months. At about 2 months, we can move the food from the spoon to the back of the mouth. 6 months, that gag response declines a little bit and becomes more used to the feel of the food, but still kind of has that gag reflex that we may also have as an adult. And we can move food now from not just front to back, but from side to side. Again, as we just discussed, the eruption of teeth are happening at this time between that 6 to 12 month period. We're now able to chew softer things, graduating to lumps, to bigger boluses of food. You can close around the lips and clear the spoon at about 7 to 12 months, biting into food 8 to 12, coping more with biting into food, coping more with bigger pieces and bigger chunks of food then.
I'm going to get you to call in if you don't mind. If you don't, just go ahead and mute your computer, use that phone number, dial in. I just feel like that we'll get a better sound for you and that people will be able to hear you better. So when you dial in, you'll need to mute your computer so it doesn't echo. Did you get the number? Do you need it? You have it? Okay, thanks. You're doing a fantastic job. Great information. It's amazing. Working with children, that has to be a fun job anyway. So guys, just give us a second and we'll get it back started. I just really want to make sure that you don't miss anything. I think the information that she's given out is so valuable. Alyssa put the number in the chat. If you need to look at the chat, you can push the chat button. It'll have the number to dial in with the code. See where it says chat? Again, thank you everyone for joining us. We are really excited to have everyone on, and please make sure that at the end of the webinar that you fill out those surveys and let us know what else you want to see, because it means a lot to us to bring the information that you want to also hear. It'll just be a second. We're just fixing the audio. If I know a couple of people just joined, we're fixing the audio so that we'll be able to continue. I just want to make sure again that you have it really nice and clear. You're on mute, so I can't hear you.
I'm dialed in, but I was wondering if you can hear me.
No, Alyssa, can you help her out here?
Hey, doctor, can you say hello to me?
Mute your phone. There you go.
Okay, I need you to unmute your phone, please.
The phone is unmuted, but it's saying that I'm an attendee.
Okay, but I can hear you, and that's the most important part. So I think we're going to be good to go to move forward.
Well, no, she's not. She's not on her phone. She's on the live chat, Alyssa.
Yeah.
Can you mute your computer? Oh, it mutes the phone.
No, I think we gave her. I think she needs a panelist number to dial into, Alyssa. I think we gave her another number, but it's not a panelist number.
Okay, I see. We have some comments. Everyone says that they can hear her when she unmutes. Hi, Dr. Hishaw. How are you? We're excited to have you in a few weeks. Okay, Doc, let's have you unmute and we'll keep moving forward.
Do you want me to continue on the computer?
Yeah, it actually sounds better now. So why don't we go ahead and try it? And then if we in the meantime, we'll look for a panelist number for you. Go ahead and unmute. There you
No
go.
problem. Okay, so this will also be available to you. We've kind of just gone through the initial from birth to 2 years, 2 to 4 years of age of oral motor development and the function of the lips, jaws, and teeth. And really just to say, it's more than just teeth that's happening at this time. Let's talk about what we should be asking and really looking and thinking at this time, are these things that I'm asking during my child visit? And what should I be adding to know what's happening at that phase right now during feeding? So initially we want to know, how is the child feeding? Are they breastfeeding, bottle feeding, spoon feeding, using their fingers? Just a general sense of how they're intaking food, because that lets us know, are we on the right timeline? Are we really supposed to be breastfeeding? And in our practice, we kind of give families a little bit of leeway in terms of how they decide as a family how long they want to breastfeed. But we do counsel them through in order our AAPD and AAP recommendations for breastfeeding guidelines, bottle guidelines, spoon, fingers. What should they be doing at this time? Okay. And then what are they eating? Because a lot of times you may see or hear, well, my child is 3 or 4 and the pediatrician told them to drink Pedialyte, at 1, and they are now still drinking Pedialyte. And that goes, why are we still doing that? Is it necessary? Are we on the right growth curve? These questions are just probing to ask more questions, right? How long does it take them to eat? Do you know the typical amount of time that it should take for an infant or toddler to eat? It's about 30 minutes. So if we're having prolonged feeds, that means something is happening. That means maybe there are issues or dysphagia that aren't allowing us in terms of our swallowing mechanism, as we talked about in the beginning, to allow us to push the food back. Maybe they're pouching food and not chewing it properly. Maybe there's something uncomfortable in their mouth. Do they gag? That's another thing as we were talking about overall growth and development that we were bringing up. It's important to know because it's important and tells us what's happening in the overall oral cavity of the mouth and how they're intaking food. Do they tend to be gassy afterwards? I hear this lots of times with my little tongue-tied tissue babies, right? They tend to be gassy. They're taking in additional air. They're just doing a whole lot. Stomach seems to be really distended and they're constantly passing gas. That's something that tells us something is happening incorrectly with the feeding and swallowing mechanism of our child. Do they fall asleep eating? Not supposed to particularly fall asleep eating. Our younger babies do, but as we get older, we're not supposed to fall asleep at the dinner table. Have they been diagnosed with a lip or tongue tie? Do we have tethered tissues going on? Do we see tethered tissues? For some of us that are on today, we may release them. For others, we really just want to look or ask so that we can refer on and make sure that the things that are happening properly as we're feeding are going the right way. Because in that portal, what's happening? Growth and development. If we're not developing properly, if we're not bringing in food properly, we can't digest it properly, we can't grow. And so dysphagia is an extremely overlooked area of feeding and really underdiagnosed. We just want to recognize it. Again, we don't have to treat it, but then we have those medical relationships where we can do a swallow study or we can tap into our aerodigestive team. Those are the things that get our child moving forward. Let's transition to speech. Our next part of the puzzle. Are we really listening when a child is coming into our office, when they're talking to us, when they're expressing what they're doing and what's happening? Are we listening in for cues? Let's talk a bit more about that. Because as we know, speech and language is an essential part of any child's development. I really like speech, and it's because we get to see it in 6-month increments and bursts of speech that are happening on the right track. Did you know generally between the age of 2 and 3 is when our speech and articulation really is something that we are paying more focused attention to? That's the time when generally, if we're going to refer to initial speech therapy or something, or if we've been watchful waiting, a tethered tissue, tethered ties, we may start to think about releasing at that time. And we know the importance of that because we're tracking those milestones. I want to look a bit at those milestones because to me, if we understand where we should be, we know where we're going, right? And knowing this also helps in behavior management reinforcement because we're talking at their level, honestly, and we're realizing what they should be able to articulate to us, and then kind of how we need to articulate to them so that they understand. So I hope as we're doing this, you see more clearly how alone this can guide. These 4 principles alone can guide your dental visit and the things that we need to ask. Let's dig a bit into the milestones before we go to what to ask. Looking between 1 to 2 years of age, those speech sounds, I find it just marvelous in terms of what speech sounds happen during those times. And if you're thinking again regarding growth and development and that oral cavity, it's really because palate's developing, tongue's developing, mouth is growing and expanding. The ability to make those articulations of those speech sounds happen during that time. And so at 1 to 2 years, we have lots of new words happening, naming and pointing and pictures and who, what, where. But check it out. Why? Doesn't really happen until 2 to 3 years of age. Can you believe that? And so those speech sounds that are happening during that time and the why, and understanding opposites like up, down, and using words like in, on, under, putting words together. This is what we're graduating to. And that's really what you're listening for. 3 to 4 years, you begin to develop other sounds. 4 to 5 years, even more. And so as we're listening to our kids and they're coming in for those visits, we're asking those questions, we're really seeing, okay, I see what's happening here. Are we on track? Are we not really on track? what's happening there. And as we look at what's appropriate, remember those socioeconomic determinants of health, things like socioeconomic status, exposure, reading, parent IQ, educational level. Those are all factors. So what do we ask? Are they speaking? And this is really sometimes because for the shy child, you may not hear them speak. They may not say anything to you during the dental visit. So you want to ask, are they talking? Because at times when I have asked, sometimes I get no. And they may be at an age where they should be saying at least 50 to 100 words. And if they aren't speaking, we really have to identify what's happening in terms of growth and development that's doing that, and connect with the pediatrician to see if there's something they're noticing also. Are they age appropriate in their words? That we go back to what we're looking at in milestones. Are we pronouncing letters that we're supposed to be pronouncing at this age? Are we moving along that continuum? Do they sound hoarse? This is something that's sometimes a little difficult to pick up because our toddlers usually have sort of a raspy voice. And then again, when do we see that raspiness? Sometimes during puberty, right? With our teenage boys, right? And so that hoarseness though may indicate some inflammation, may indicate some infection that's happening. And you really want to pick up on it. And sometimes you just ask because of course, our parents know their child best. So you want to know, do they sound hoarse to you? Is this a normal way that they express themselves? Does the household speak more than one language? That's important. Why? Because sometimes we see a little bit of delay in overall speech and growth and development in that speech realm when we speak more than one language in the household. So we want to make sure and ask those questions. What words can you fully understand as a parent? Remember, they're different, right? So what words are you fully understanding as a parent, and how do they relate to the words that I'm hearing on a daily basis? And again, have they been diagnosed with a lip and tongue tie? We want to know. Remember, this is the second time I've mentioned that in our overall evaluation, and we've only gotten through our first 2 segments. These things are important in determining whether or not our child is going to grow properly. And we have to continue to ask those probing questions to make sure that we're on the right path. Moving on to another piece of the puzzle, breathe. The ability to breathe without restriction. Take a breath. Let it out. How does it feel? For me, I'm a little stuffy. So right now, maybe not as pleasant as I'd like for it to feel. But the ability to breathe without restriction is a wonderful thing, and one that helps you to continue to grow throughout childhood without restriction. Big deal, right? And those are things that we want to continue to ask our families. We want to know, are we breathing properly? What do we want to know? Well, we kind of already know it. Airway is life. And that's a nod to Dr. Megha Dasani, because that's the name of her new book. The airway, it clears the path to growth, speech, feeding, not just surviving, but thriving. We elevate this based on effort, efficacy, and the effects of all of that. Let's take another classroom look at child versus adult airway as we move through what we want to pay attention to. So, there are a number of developmental characteristics that distinguish the pediatric airway from the adult airway. The pediatric airway is smaller in diameter, as you can see on this diagram, shorter in length than the adults. The young child's tongue is relatively larger, as we talked about before with feeding and swallowing. And And relatively, the larynx in the infant and the young child is located more anteriorly compared to the adult. The epiglottis in the infant and the young child is relatively long, floppy, narrow, and in children younger than 10 years of age, the narrowest portion of the airway is below below the glottis at the level of the cricoid. So the smaller caliber of the pediatric airway leads to a lot of other things, right? The larger tongue, the floppy, relatively longer epiglottis predispose young children to airway obstruction during sedation, during sleep, during many other times in their lives. And that's why when we put, in addition to the large occiput of the infant, that places the head and neck in a really flexed position. And so we're constantly monitoring, how are our kids? What's their stance? Are they able to move their head in the right position? Where are they positioning themselves? How are they sleeping? And what's their position when they're sleeping? Because that all leads to how we overall look and how the breath is happening and what they're taking in with every breath. What to ask? Well, does the child snore? Snoring isn't really a normal thing for a child to do. It indicates that there are lots of other things that may be happening. And granted, keep in mind, for purposes of this presentation, we're talking about the healthy child. Because as you know, a subset of pediatric dentistry is treating children with special challenges and needs. And their growth and development may already be very different from what we have along the way. So when we're looking at growth and development, we're asking these questions. Does the child snore, right? That gives us a window into what may be happening while they're sleeping. Does the child mouth breathe? When does that happen? Does it happen while they're just sitting and resting? Does it show maybe that the tongue is hanging out during that time and therefore they're trying to open their airway and get more air in by doing that? What does mouth breathing really indicate to us? It definitely indicates that we need to dig deeper. Does the child have a clear respiratory passage most of the time? And what I mean by that is, do they seem stuffy? Do they always seem like Nicholas, the child I was talking about before? Do they seem like they're always congested? There's always something going on. What's happening during that time? Do they have an overall clear pathway that we want to make sure is properly diagnosed and properly being treated? Because again, these things all affect how we're going to continue to grow through that trajectory. Does the child have any other respiratory illnesses? It's interesting how many times we ask, and that's why I gave these series of questions, because sometimes we ask one question, it's a no. We ask another question, oh, it's a yes, they're taking X medication. Oh, well, let's talk more about that. And so these questions just kind of help you bring out a little bit more in terms of that conversation that you're having. Does the child drool past normal drooling age? We expect our infants sometimes to drool more than others, right? And as they're teething, we may drool a little bit more. But if we see a 3, 4, 5-year-old that has excessive drool, that may mean that there's some inflammation or something going on in our airway that we really need to address. Drooling does indicate that there is something additional happening that we need to pay attention to, that we need to focus on, and make sure that as we're asking these questions, we ask, well, do they just find that their shirt is wet? Is it a whole bib? How many times does the child wear a bib? And how many times do they have to change that bib? Things of that sort. Those are all proper questions to ask as we're moving forward there. And again, has the child been diagnosed with a lip or tongue tie? Again, we're just putting the pieces of the puzzle together. What's happening here? How are we moving along? How is our child breathing? How is our child thriving? Moving on to another part of the puzzle. One, finally, right, we're very familiar with, smile. This, you notice I put last. And it's because we know about this, right? I'm going to challenge you again to think beyond the teeth. think beyond the baby teeth. And check this out, even more to think before the age 1 visit. Wow, okay? Before the age 1 visit. Let's think about this a bit more. What we know our sequencing of eruption is very important. And honestly, now varies tremendously based on race and ethnicity. And it really queries us into, okay, we know how eruption should happen. What more do we need to know? We know that around that 4 to 6 month mark, we're going to bring in new teeth. We should know at this point, the patterns of which that happens so we can identify if patterns are abnormal in that happening. We know as we transition from our primary sequence of eruption to our permanent sequence of eruption and how that should look, and are evaluating that hopefully through x-rays, hopefully through touch and feel as our children are coming in and continuing to grow. Well, you remember I said I'm going to take you back a little bit more? Back to the classroom again. This, of course, is the real beginning. The realization that there are morphological stages and physiological stages at any point that can be disrupted by simple or complex challenges to the womb or the child in utero, or what's happening to the mom as she is growing and developing with the child inside. So at any stage, something can happen. And as you're looking through all these stages, you remember this? I kind of go, ooh. We're looking at the thickening, the bud stage, the cap stage, the bell stage, all of these things that are happening during the morphogenesis of that and the cytodifferentiation phase. And we know, and we have to remember that anything can happen during these times. So we're, again, as we're trying to put together the pieces of the puzzle, we really want to see, if something is going on with the tooth, when do you think it really happened? Can we predict a timeline of when it happened? And bonus points if you can really predict at what week in utero it was happening, right? We go back to almost like a board question. But if we can do that, we really are able to dig in to some of the factors that happen of weaker teeth. We really are able to dig into some of those genetic abnormalities that are happening during that time. And then we're really able to forecast what may be happening in the future, right? And so what do we ask? We ask a lot of questions already, right? But I hope to add this to your overall discussion. One of the questions, any familiar history of tooth issues? I like to ask, any curious findings, missing teeth, extra teeth, anything I need to know. It's amazing when I see, especially families, when the dyad comes in and, they're talking and they're asking each other, hey, let me look in your mouth. Is there you're missing a tooth? You have an extra tooth? Wow. And now we really start to have this conversation and engagement, because then that's when we're moving forward. We're really pushing into how we're going to help this child to have the best oral health possible. Any maternal or feeding issues fetal issues during pregnancy. And really that just dials back to the birth mom. Was it a challenging first trimester? Was it a challenging pregnancy? What happened at birth? Was there anything that we should know about? Because any of those times, as we saw the phases of tooth development, if something happens at that time that we may be having some of that differentiation, it could change the whole trajectory of that tooth in just a couple of hours. So we really want to pay attention to that. And as teeth are developing at about 4 to 6 weeks in utero, we know that it starts pretty early, sometimes earlier than we know that we are pregnant. When do teeth start to come in? I like this question because we sort of are able to mark. And those a lot of times are based on genetics. They're based on overall girls versus boys. We have different phases in terms of where teeth come in. And that's why we use our tooth chart as a guide, but it doesn't exactly tell us exactly when teeth should be coming in. So we should be asking and looking for that. Any trauma to the dentition, even as we see kids at our age 1 visit, they may have already had trauma to their dentition. And we want to know so we can help counsel families in terms of what the future may look like, not just for the baby tooth, but for the adult tooth also. Any oral hygiene habits, anything like that that we need to know. Thumb sucking, finger sucking, curious findings, gnawing on things, any curious foods that they may be eating to determine, okay, is this normal? Is this abnormal? Remember, we just want to recognize, treat it if we can, this is all around, or refer if we need to. And finally, again, I go back to that question, have they been diagnosed with a lip and or tongue tie? We want to know. Sometimes we're the ones, I have babies as young as 2 days old, coming in. And so I may be the one who diagnosed them, but they may not get diagnosed until later in life. And so those are things that we continue to ask. Here's another chart I love about what we're asking, because as we're doing those questions, we're probing. We want to see what's going on, right? We want to see how growth and development is happening now with the teeth, because we've asked all the questions before. And so we're looking at those biological, protective, and other findings. Does mom or caregiver have active caries? Where does that put us? That also helps in our counseling, right? That helps us kind of target where we're going to go from here in terms of each visit, because we want to have a plan. We want to make sure that as we're looking at the whole child, we've made sure that we've put a plan in place to help them continue to grow. And what did I say before? To thrive. And so those protective factors of optimally fluoridated drinking water, do they use fluoridated toothpaste? Are we giving topical fluoride? Do they have professional dental care? All of those things are things that we're looking at in terms of our caries risk assessments and looking at in terms of how we're going to continue to guide our families along in this journey. I've taken you through a short but long journey, right? Because what we are realizing is there is a lot that we have to know, a lot of things that we haven't quite gotten to yet that we still need to learn. The educational opportunities are still out there as we're moving forward, but we are the keepers of the head and neck, including the teeth. Many may ask, shouldn't the pediatrician pick this up? Yes, they should. But have you seen their well visit check notes? They are much, much longer than ours. We have a major role to play in the partnership, and we can completely change the trajectory when we ask the right questions, we recognize, we treat, or we refer. And tonight, we're really just touching the tip of the iceberg, as we've not talked about sleep patterns, habits, motor development, all the things that I really, really love to talk about and add on to what we're doing right now. But as you can see, there's so much to discuss, so maybe I will be back. But I want you to see what my eyes are seeing when we see a child walk through the door. And now, hopefully, you will too. Can we do this alone? Absolutely not. It includes our entire team. First at home, with our families, with our team in the dental office. I had a professor, Dr. McKeever, remind me that the physical examination of a child starts when they walk through the door. Do you believe that? Because at that time, we are monitoring their gait, how they're standing, how they're moving, how they're playing, how they're interacting. I can't believe how many times my admin team has picked up, something just doesn't seem right. And it's not like they have to diagnose it, but they're telling me, check this out, watch, look at how this is happening. And then we get to probe a bit more. We get to really look at what's happening. Then as they get into the back, our hygienists, our safety patrol, our other team, our first reporters, of course, our parents, then start to fill in those holes, fill in those gaps. And then we look at partnerships within our medical team, our ENT, our pulmonologists, our orthodontists, our PCPs, you. Remember, I want you to recognize normal and abnormal patterns of feeding, speaking, breathing, and smiling. And again, recognize it, Don't necessarily have to treat it if you don't know, but refer and have those relationships. Remember the kid I spoke about in the beginning? Well, that's my son, Nicholas. And I was that parent who sat in a course one day and found a diagnosis and an answer. I challenge you in the next child you see and examine to think of these 4 tools of evaluating growth and development and see if you can help another family or your own. Thank you for tonight, and back to you, Kay.
Fantastic. Let me just get everything turned on. Great job. So we do have some questions, and I'm just going to ask for everyone to please go in. And there's a Q&A. So you, and Doctor, you can see it too. You can actually click on it and it'll open it up.
Okay.
We do have one. So let's go ahead and start. So everyone, if you would just please start, we have 10 minutes left that we can actually go over a few questions. So does the wear facet on let's see, composite primary molars a concern if a patient snores too much? The posterior primary molars.
Yes. Thank you so much, Sherry, for this question. If we start to see wear facets on posterior primary molars, that is a concern. And the concern, and especially if they snore too, right? Because that means something is going on airway-wise. Sometimes if we see grinding or if we see wear, we start to ask, does the kid grind? When do they grind? It may show some sort of sleep habits that need to be changed, or it may make us dig deeper into some neurological changes that need to happen.
Wow, fantastic. So hopefully we answered that. If you have any other question, please bring it in there. And guys, please write in your questions. So then there's another one from Dr. Luckman. They want to know if a pediatrics dentist, can they actually prescribe a sleep study? That's really a good question. Is that?
Hi, Dr. Luckman. Absolutely, we can prescribe a sleep study. The way I do it is I don't want to disconnect the relationship between their child, the pediatrician, and us, right? Because we need those relationships to continue to really effectively manage the child. So I let the pediatrician know what my findings are and that I recommend a sleep study. But then and ask, is it okay if I do this? And typically it's yes, but I always ask first because sometimes the pediatrician may be working with a team that they already have, or sometimes they can get the child in a bit faster. So we can prescribe and make sure that it happens, but then we can make sure we connect with our pediatrician to let them know what we're doing.
Fantastic. Okay, and so you see your third question. What is a different diagnostic? Go ahead.
Yeah, so hi, Arthi. The differential diagnosis for attrition facets in primary molars. So we know that it's based on a tooth to tooth, right? There's something happening that's causing that friction to happen. And the thing that we need to determine is it something that's happened neurologically? Is our child a healthy child? Those are the things we're looking for. Are they a healthy child? Is it something that's happening neurologically? Is there something that's happening airway-wise? And we can start to probe, especially with some of those questions. And the one thing I didn't say is that I put together a one-pager that everyone's going to get after this presentation so that you can remember, just to kind of jolt your memory and ask those questions. Because as we're asking those questions, we can sort of look at, okay, what this may be pointing to and who we point it towards.
Fantastic. So let me just ask you a question too. So tell me, do you have any tricks for working with children? Like when you have a child that's terrified, and just like, well, my granddaughter, luckily I started her at a young age, but what do you do? How do you handle, do you allow parents to go back with the kids when you bring them into your office? Can you give us some tips on that? Like, what do you do for a child that's terrified?
Absolutely. So I like to say it starts before they walk through the door. And so a lot of it, we encourage families, like when our families are making that new patient visit, as soon as their appointment is entered into our system, they get an email. They get an email of a picture of us and a click to tour the office, because you kind of want to ease them in, right? You want to ease them in and let them see what the office looks like, let them know in order to make sure that they are kind of forming that relationship before they walk through the door. Then, we also recommend some books that they can read prior, so that they're saying, okay, this is what we're going to do when we get here. This is what we're going to do here. We're going to walk through here. I also encourage parents, we need them. We need the positivity to be shining through. And, I see the memes on IPO all the time because of the parent that wants to like jump in and be overly, helpful. And the parent that's like terrified because they're terrified of the dentist. We just want some positivity. We can take it from there. But, reading, really talk and knowing your child, because sometimes some kids don't need to know everything that they're going to do because it's going to overwhelm them. But other kids want to know the steps. And so we just kind of walk them through that. So it begins before the visit of showing off who we are, what we do, how awesome we are, and then walk them through that dental visit when they get in.
And your results are usually really good, right? With the time so the first visit's a fun one, right? You make it fun.
The first visit, we do our best. At this age one visit, it can be tricky. And, there aren't that many age oneers, and I'm sure those that are on today that rock of our age one visit. But we do it knee to knee. We're careful, we're comfortable, we're singing, we're still positive, and we get through it. And we see that age one visit kid come at in 1.5 and 2.5, and they just grow. They just develop from there. So that patience is key.
And you know what? And that's challenging. We think it's hard in a general practice because we have to wear masks and all this stuff. Imagine what it's like having to put all this new COVID stuff in place. And on top of that, deal with children who are already terrified. So yeah, you know what? Like that's really, I've seen some of your videos on your website. You've done an amazing job. I mean, I could see how kids could just be drawn to that and be excited about going to your office. So I think you have a couple of more questions. You might want to look at those. I think that might be close to the same. It's about your sleep study. So let's see. Do you have to be a board certified physician?
Okay. So Dr. Wilson, if I understand correctly, if a child is diagnosed with a sleep disorder, such as sleep apnea, are they treated with pediatric sleep appliances or like adults? And generally, they may be surgically treated. Removing tonsils and adenoids may be a start, or tonsils or adenoids may be a start, depending on the level of their diagnosis. And so they typically may not start out with a sleep appliance, but sometimes as we're training them out, we may start out with some appliances so that we can get them over. So surgery is not always the first go, but sometimes for our little ones, it may be that go that happens sooner than later. The next question was by Dr. Arti. Can or should a sleep study be recommended if there is no history or symptoms of obstructive sleep apnea with attrition facets in primary molars, and if the child is healthy otherwise? I like this question because that means you've done the probing, and I always want to connect back the dots with the pediatrician or recommend conversation with ENT so we know, okay, I mean, sleep study, it's pretty invasive, to be all honest. If you've never had one, there are a lot of things connected, but it's the gold standard. So there's no harm done if a sleep study is done, but other than that, you may be looking neurologically. We may be doing swallowing studies to see what's happening. There are lots of paths that we can go. So that's why I was recommending, if we have that team, and this goes to Dr. Patel's question in terms of what the first step is to take to start finding places that provide sleep studies. One, if you're lucky enough to be close to a children's hospital, generally they'll have a sleep study team or a great digestive team. I've been very lucky to have that team. but also knowing that not every physician may be airway centered, you really want to ask those questions. You know, what age would you do a sleep study? How do you feel about sleep studies for children? And what's the best method for getting that obtained? And so some of that may start with your colleagues, and some of that, if you're close to a children's hospital, may start right there. I think I answered them all.
Let's see, is that the last one? I just had to switch over really quickly. Let me pull the screen back up. Hold on 1 second. Did we answer them all? Where are we? Let's see. I think we did. Did we get to all of them? Does it look like we answered them all, doctor? I think we did.
We did.
So fantastic. So let me just close this out real quickly. I definitely want to say thank you so much for an amazing presentation. And definitely we are going to have you back. You know, there's over 100 people on this webinar who really wanted to hear the information and talk about learning a lot from you. It's amazing. And I really appreciate what you do for everyone and for everyone tonight. So we will definitely have you back. So thank you very much.
Thank you.
So, okay, everyone, I just want to give you a little brief update on the upcoming webinar. So, but first of all, if you have your phone close, one of the things that you can do is you can scan this QR code. We have 2 complimentary webinars per month. And if you scan that, it'll take you to the website to kind of go over, you know, what's coming up so you can make sure you reserve your seat. Coming up soon, what we have next is, so we have Bob's coming back. Bob did a webinar for us on maintenance when everyone was shutting down, and it was just unbelievable. So we have had more requests for Bob to come back and talk about how do we maintain our equipment to keep it up and running. So Wednesday, March the 10th from 7 to 8, mark your calendars because Bob's back. He's going to be giving us some great information. Who knows, maybe he'll even give us a cheat sheet. So please make sure you mark your calendars. And then on Wednesday, March 31st from 6:45 to 8 p.m. Eastern time, we're going to have Lucy Hobbs is going to be presenting Women in Dentistry, Celebrating History, Making History. So we are going to have a panel with 3 amazing dentists on it of all different levels, of all different times. And we're going to be going over some really good information. So please make plans to join us. Again, that's going to be on Wednesday, March the 31st from 6:45 to 8 o'clock. And then Dr. Converse is going to be back. His workshop was so good. He is definitely going to be coming back. So we're going to be doing a workshop with him again. And it's going to be going over oral cancer detection, biopsies, and techniques. And it's going to be a good one. You know, just the excitement he brings and what he does, I can tell you it's going to be amazing. So please make sure that you sign up. The workshops are really inexpensive and you're going to get a lot out of it. It's going to be $49. Again, it's 2 hours and you will get CEs for that. It's going to be on April the 23rd from 1 to 3 Eastern time. Again, that's April the 23rd from 1 to 3. It's going to be a fantastic workshop. We look forward to seeing you there. And with that being said, I had told you earlier, you know, for any reason, if you called in on your phone, don't worry, just make sure that you email me your information, email me your name, your telephone number that you're listening to the webinar on, and the course title, and we will make sure that you get your CEs. You're going to mail all that information to practicecoaching@benco.com. Again, that's practicecoaching@benco.com. It's going to take about 30 days for everyone to receive your CEs, but don't worry, we'll make sure that you get them. And thank you so much for attending. Again, doctor, thank you. Your tonight was fantastic. Thank you so much for your time. Bye, everybody.
Good night.